Hello guys, so today's tutoring is going to be on fractures. I'm also going to be touching up a little bit on pressure ulcers towards the end of this review because it does go hand in hand with fractures, but it's a little bit of more of a fundamentals topic. So your actual med surg topic is going to be fractures. And if by any chance you guys hear like background sounds or anything like that, I do apologize in advance. I'm not home, I'm in my parents because my internet is having issues, and that's why some of you guys might be listening to this late, um, or you already took your exam, unfortunately, because of my internet issues. So I do apologize for that. All right, so we're going to talk about fractures and we're going to talk about what basically we as nurses are going to do and how we're going to care for a patient that has a fracture. So, first, we need to know the difference between the types of fractures that we're going to be seeing because depending on what fracture the patient has, it's what we are going to be doing and how we're going to care for them. So, the first thing that you want to know is if the fracture is a closed or open fracture. I always think about it as is the skin open or closed? That's how I always think about it. So if it's a closed fracture, that means that the bone did not penetrate through the skin and it didn't break the skin. And if it is an open or complex fracture, that means that the bone fractured, it broke, and it literally went through the skin. So you could physically see the bone outside of the patient's leg, arm, wherever the fracture is. Okay, so think about that when you're thinking about the closed and open, think about the skin. Then we're gonna look at if it's a complete or incomplete fracture. Did the fracture completely break through the whole entire bone or the extremity, or is it an incomplete fracture that it's half fractured? So meaning, let's say that we're talking about, I don't know, the humerus. Did the fracture go through the whole entire humerus bone straight across, or is the humerus bone fractured, halfway? Okay, so it is. I do recommend you guys looking at pictures as well to help you guys visualize this. I personally am a visual learner, so I really recommend you guys looking up pictures so you guys could get a visual of what I'm letting you guys know and talking to you guys about in the tutoring, okay? And then we're gonna go to the types of fractures. So we have linear, oblique, transverse, longitudinal, and spiral. So I have the little pictures here. And as you can see on the top, we have the open fracture, which is the one that I was telling you guys about, the penetration through the skin, and then the closed fracture. So the patient has a fracture, but it didn't go, the bone didn't move outside of, the inside of the patient. And then on the bottom, we have the different types of fractures. We have the transverse, which is basically a fracture straight across the bone. We have the spiral, which this one is going to tell you that it's usually child abuse or some type of abuse, because usually how are you going to get like a spiral fracture like that? So usually when kids and children come to the hospital and they have a spiral fracture, especially something consecutive, that you notice that they have a spiral fracture every 3 or 6 months. This is kind of like a little sign that's telling you that they might be in an abusive household. Then you have your green stick fracture, which is just literally like a little piece of the bone fractured out. You have your comminuted, I think that's how you say it. But basically, just think about shattered glass. So usually this happens in like motor vehicle accidents and things like that. It's literally like the bone shatters, like if it was glass. You have your oblique, which if you could see, it kind of looks like your transverse because it's kind of like a line, but this one, it's not gonna go straight across. It's gonna kind of like curve down, and it doesn't completely break the bone. If you could tell, there's still a part of the bone still attached to itself. Okay, so if you kind of like bend the bone, you'll see that it's still attached a little bit. Then your pathologic one is similar to the transverse as well because it's straight across, but this time the bones are actually separated from one another, so you could see like the gap in between. Whereas in the transverse, there is a fracture, but the bone is still close together. And then your stress fracture is usually seen and noticed in the toes or the fingers. It's due to stress, like or probably like if something falls on your toes or your fingers and it weighs a lot, this could cause a stress fracture. Okay. So the risk factors usually for obtaining a fracture is, well, you could get a fracture because playing sports, physical abuse, like I said, with the spiral fractures, a motor vehicle accident, if you fall. Usually the falls are more severe when it comes to the elderlies, especially the hip fractures. Long-term corticosteroid use could cause fragile bones, which could cause osteoporosis, and then that eventually leads to fractures. Menopause, if the patient is not on any medications that is helping with estrogen levels, low estrogen levels lead to osteoporosis. Osteoporosis leads to fractures. Excessive exercise and weight loss could also damage and cause fractures. And then the age and lactose intolerance. Okay, so anything that you know that kind of hurts the bones in a way and puts them like fragile is always going to be a risk factor for fractures. So the clinical manifestations that I want you guys to make sure that you guys know is your neurovascular assessment. Your neurovascular assessment is for sure going to be on your exams. It is going to come up now and eventually sooner or later in another class. Every time that you guys talk about fractures or compartment syndrome and all those things that we'll talk about in a little bit, you guys are going to be talking about the 5Ps. So you guys need to make sure that you understand, you at least memorize it. Or I don't like memorizing things because I kind of forget everything that I memorize, so I try to remember it by understanding why we're doing it. So just do whatever is best for you, but make sure that you know your 5Ps. So every time that a patient comes in with a fracture or anything, we are going to be assessing this patient for the 5Ps every single hour for the first 24 hours that we have this patient in the hospital. And then we'll check them like between 1 to 4 hours. But the first 24 hours are very, very crucial, and it's very important for you to be doing this every single hour. Okay, just because one at the beginning they don't have an issue, this doesn't mean that they could develop into compartment syndrome or any other abnormality. So the 5Ps is, does the patient feel any pain? Does the patient have a pulse? Is the patient's skin pale compared to the other extremity that is not fractured? Does a patient have paresthesia? So by this, you're going to be like basically like poking their skin or touching them and asking them if they feel that. And then does the patient have paralysis? So you're gonna tell the patient to move the extremity. So you're going to be assessing this patient. If the patient doesn't have pain, it doesn't mean that's serious. But if they do have pain and you give them medications and the pain is not resolving, then this is something that you really have to notify the provider, because it could be a sign of compartment syndrome. And like I said, I'll talk to you guys about compartment syndrome later on in the PowerPoint. But unrelieved pain is very, very important to treat. And it's really important for you to tell the patient that if you're gonna give them medications, to let them know, you're gonna assess their pain levels with a scale of 0 to 10. If you don't see that their pain is improving or if it's getting worse, this is something that is very concerning. Now, your pulse, you should be able to feel a pulse wherever the fracture is. You want to find like the pulse nearest to the fracture without causing any pain. and you want to make sure that you feel a pulse. If you don't feel a pulse, that's something that you have to tell the healthcare provider. If you see that the patient is pale to one extremity compared to the other, this is not good. Remember that pallor is basically no circulation is going through that extremity, and that's why it's pale. Um, so if you see that the extremities are different colors, you do have to notify the provider. Paresthesia, they should be able to feel the areas around the fracture. So if they don't, this is a bad sign. And then paralysis, they're when it comes to paralysis, obviously they're not going to be able to move depending on the extremity. Like for example, if they have a fracture in their elbow, don't don't think or don't expect them to be able to move their elbow because their fracture is there in the elbow. Okay? Um, but they should be able to move their wrist, if that makes any sense. So you always want to see if they can move areas around the fracture, but not necessarily where the fracture is. So let's say that the patient has that fracture in the elbow. I'm gonna have the patient move their fingers, move their wrist around. Maybe the wrist might not be able to, it's gonna hurt them, or they might not be able to move it because there could be like a muscle, excuse me, or a tendon that will cause pain to the fractured area. So it all depends, but they should be able to move their fingers. Okay, so you also want to look for edema and swelling, any pain and tenderness around the area, muscle spasms. Usually the muscle spasms are the ones that we're going to be treating with the tractions, which we'll talk about in a little bit. You want to look out for any deformity. So usually the deformity will be, it could be open or closed fractures, because maybe the closed fracture, like the bone moved and it just didn't go all the way through and penetrated the skin, but you could probably see like the area like not formed correctly. You want to look for ecchymosis, like redness of the skin, bruising, contusions, and things like that. Loss of function, and crepitation is basically like a cracking sound. So if you hear a cracking sound, like usually you could hear this like in the hip, um, I think in the shoulders and the elbows, I believe as well. Usually it's in like the joints, where you could hear that cracking sound. Okay, so that's not normal. Crepitation is not normal at all. So when a patient comes into the hospital and you suspect a fracture, apart from everything that's on the slide, the first thing that you're going to do, and I want you guys to keep this in mind because you guys are going to be tested on this. Your priority when a patient comes in with a fracture is to splint the extremity. Think about when you guys do priority questions and you do the ABC. Well, now you're going to be doing your fracture priority, and your fracture priority is splinting the extremity that you think could be fractured. Even if you don't have a confirmation of a fracture, you're splinting it. The reason why is because if it is fractured, you don't want it to you don't want to cause any more damage to it. Um, so the first thing that you have to do is splint. Once you have a patient splint, then you could do all the stuff that you need, your vital signs, whatever you have to do, the history and all that stuff. So make sure that you guys remember that for your exam. You guys for sure will probably get a question, a priority question, and the the main thing that you need to do is splint the extremity. Okay, do not forget to do that. So once you splint the extremity, you're going to get like a kind of like a history on this patient. You're gonna do like a history and physical exam, ask them if they've had a fracture before. You want to see if they have any diseases, diagnosis, and everything that could lead to this fracture. You also are going to do an x-ray. If there is a necessity, then they'll do a CT scan, but usually an x-ray will pick up whatever fracture it is. Then you're going to, once they figure out what type of fracture the patient has and all that stuff, they'll figure out if it needs, if we need to realign the bones, if the patient is going to need a cast, a traction, an external fixation, or internal fixation. We'll talk about it as well after. And then for open fractures, usually it's going to be surgery. Okay, because first of all, remember, open fracture is the one that's penetrating outside of the skin, meaning this patient now is at high risk for obtaining bacteria and infection and stuff. So they'll do a surgery, debride that area. They're going to irrigate the whole entire area. They're also going to give the patient a Tdap, a tetanus and diphtheria immunization. Even if the patient received it, I believe they still give it because of the penetration, and you don't know if they got in contact with anything. They're gonna put them on prophylactic antibiotics just in case, and then they're gonna put them on immobilization. Okay, so your neurovascular assessment, we already talked about it. I already explained to you guys that you guys have to do the 5Ps every hour for the first 24 hours, which is very crucial. So make sure that you guys know that for your exam. You're always going to assess your patient using the 0 to 10 pain scale, making sure that they're assessing if the medications are working for the pain and so on. You're going to check the capillary refills, the pulses, the skin temperature. You're going to be comparing it to the other extremity, making sure that there is no abnormalities. So for the nursing care, apart from splinting, like we talked about, when the patient comes in, which is the first thing that you have to do, which is splint the patient's extremity, you're going to remove any jewelry or clothing that you find like around the area, because you don't want any compression on that area. You're going to elevate the limb for circulation, apply ice for edema and swelling. If the patient has an open wound, you're always going to put a sterile dressing on top to prevent, any more risk for infection. You're going to assess pain and do the neurovascular 5P assessment like we talked about, and prepare the patient for immobilization, because what we want is for this extremity not to move, because if the patient continues moving, like continues to move it and things like that, it could damage it even more. Okay, so to prevent fractures, and it's like basically every time that you guys learn about diseases and things like that, you always want to know how to educate your patient on prevention of things. So for fractures, there are different types of preventions. We have calcium intake, because remember that bones are basically built and maintained by calcium, and then you need vitamin D to absorb calcium. So you want to tell the patient that they should go outside to get like direct sunlight for at least 15 minutes. If this is not the case, obviously there is vitamin D supplementation, but natural vitamin D is pretty good. You also want to screen for osteoporosis. Usually it's the bone density exams. It's done every 2 years, depending on the patient. If the patient is already at risk for osteoporosis, I believe that they can do it every year, but usually the screening occurs every 2 years. And I think it's after the age of, I think for women it's when they're going to start menopause, I believe. I don't know if there's like an actual age. You guys will have to look that up. But the bone density, or the DEXA scan, is the one that screens for osteoporosis. You want to tell the patient that they should do weight-bearing exercises. This one is something that comes up on exams a lot. I think it comes up in med search exams a lot, like your proctor exams and things. So make sure that you guys know about the weight-bearing exercises. It's very good to prevent osteoporosis and also fractures. And then biphosphonates are usually given to treat osteoporosis and also to prevent osteoporosis. And then you always want to put your patient on fall and injury prevention if they are at risk for any falls. So, like I said, there's different treatments for fractures. So the more generalized and the most common one is your cast. because this is basically like for regular like fractures. Um, so the main thing here is to immobilize the extremity because we don't want it to continue to get injured. We want to reduce the patient's pain by giving them medications. And we have different types of casts. We have short or long arm or leg casts. So it depends on where the fracture is and what type of cast the patient needs. We have a walking cast. A speak up cast is usually for kids when they have hip dysplasia or for the elderlies. And then the body cast is usually when they have like a huge fracture throughout the body. So the two things that you guys need to know about the cast is the casting materials, because you guys might have a question on that. There's the plaster cast, which is the heavy one. That one cannot get wet, and it takes 24 to 72 hours to actually dry. Okay, so when you guys are test taking, the plaster one is the one that you have to keep away from water, and it takes longer to dry. It takes about a day to 2 days to dry completely. Then you have your synthetic fiberglass cast. This one is light. It's stronger than the plaster cast. It's water resistant and it dries quickly. Usually it takes like 30 to 45 minutes to dry. Okay, so for your exam, make sure that you guys know the two material casts. The cast nursing actions is kind of similar to the actions that we already talked about. We do the neural checks every hour. We apply ice for 24 to 48 hours. Obviously, you're not going to keep the ice pack for 24 hours. This means that the patient is going to probably have edema and swelling for the first 24 to 48 hours when the cast is put on and placed. So you want to ice it um, if if it's needed for the first 24 to 48 hours. So don't get confused. You don't leave the ice pack for 24 hours long. Obviously, it's not going to last that long, but just in case that kind of confuses you. Um, Now, there's another test question that kind of comes up, and this is why you guys need to know about the material. Since the plaster cast is the one that takes long to dry, you need to know how to, I guess, how to mold it and how to be able to like, uh, how can I explain it? Since it takes 24 to 72 hours to dry, you need to know that as a nurse, you cannot like touch it with your fingertips. You have to use your palms. So just in case you have to move the patient's extremity or something, or if you have to do something with the cast, make sure that you know that you cannot use your fingertips. You have to use the palms. Okay, if that makes sense. Because remember that it takes long to dry, so if you use your fingertips, you're gonna make holes or dents inside the cast. Okay, you want to also elevate the cast for the first 24 to 48 hours because, like I said, the patient is gonna have edema and swelling. So you want to also prevent that from happening if they don't have it. So if you elevate, you're kind of bringing back the blood towards the heart, and then this prevents edema and swelling in that area. Okay, you want to also ensure that the cast that is being placed is not tight because this could also cause compartment syndrome, decreased circulation, and things like that. So there should be at least a room for one finger between the patient's skin and the cast. And you also have to tell the patient, that they have to look at their cast all the time. If they see any abnormalities or if they see like a presence of drainage or like skin breakdown, um, they have to alert the doctor. Now, for patient education and teaching, you also have to tell the patients because these patients are not going to stay in the hospital with a cast on, unless like it's like a really bad fracture. But I doubt it. Like if it's a regular cast, you guys probably have seen people go to school with casts when you guys were younger, or you've gone to stores and stuff like that, and you've seen people with casts. So you do have to educate these people and these patients when they go home that depending on the cast that they have, of course, but usually the education is the same for both plaster and spica cast. The main thing that they ask you on the exams is what would you tell the patient if they have itchy skin, and you have to tell the patient that they cannot stick anything. They can't stick a hand. They can't they can't stick what are those called? The hangers. They cannot stick any Q-tips. Nothing can go inside the cast. So a test question that always comes up, and it's kind of weird. Like the first time that I saw the question, I was like, "What the heck?" Is if the patient has itchy skin, you have them get a blow dryer and put the air like in that it has like that cooling effect, and they could literally blow cool air, and then that's gonna help the itchiness. It's weird, and at the beginning when I was doing practice questions, I was kind of like I would not have imagined that that would have been the question or the answer. But yeah, that's the answer. So basically, get a blow dryer, put it in the cool effect, and then put air inside, and then that's gonna help alleviate the skin. Let's see. Another thing is that especially for the plaster cast, you have to tell these patients to cover their cast during baths and showers. Usually, they shouldn't take baths. When you guys take test questions, usually the answer choice of a bath is always incorrect. That's a little tip that I want to give you guys, because I've noticed that every time that the answer choice says baths and it doesn't say shower, it's always incorrect. And then let's see, change in mobility, shortness of breath. So they want to report any change in mobility, shortness of breath, skin breakdown, and constipation if they have a cast. All right, so that was the cast, and now we're going to talk about the tractions. So the tractions are basically to pull, force, and promote and align the fracture. So usually this is when the fractures are not the fractures, but when the bones are not aligned correctly. And usually the reason why they do the traction is because the cast is not going to be able to align the bones. The cast is just going to prevent the bones from moving. So if you put a cast on an unaligned fracture, it's going to heal unaligned, and that's not what you want. So you have to use a traction, and it's also going to decrease muscle spasms. So sometimes these patients are going to have muscle spasms because if you think about it, your muscles are attached to your bones. So if your bones are not aligned correctly, um, they're going to start spazzing. So the tractions are going to help. And for the tractions, for testing purposes, you do have to have a prescription because, like I said, there's different types of tractions. So some of the tractions are going to have weights, which we'll talk about it, but there's going to have to be a prescribed weight, a prescribed traction, and etc. The goals for the traction is basically to prevent and reduce the pain and muscle spasms, like I was talking about, immobilize the fracture, and then basically align the two bones to properly heal the bones back together. So we have different types of tractions. We have skin traction, which is usually not used for a long period of time. It's usually a short term until the patient has surgery. So it's not used more than 72 hours. You either will see the patient have tape, boots, or splints, and then you also are going to see the buccal traction. Okay. With skin traction, the most important thing is skincare. Remember that anything that's around the skin or whatever, it could cause pressure ulcers, it could cause skin breakdown. So that's why we're going to be talking about pressure ulcers a little bit after this. But the skin traction, I'll show you guys a picture of how it looks. But basically everything is outside of the skin. Now when we move into skeletal tractions, these are going to be actually like surgically like placed, okay? So we have the regular skeletal traction, which we have to provide pin care for all of these three, okay? So for skeletal traction, external fixation, and open reduction and external fixation, we are going to have to provide pin site care. For the skeletal traction, this one is the one that you're going to see the patient with weights, just like the box traction. With the external fixation and the open reduction, you're not going to see weights because it's actually going to be on the patient's skin, and I'll show you guys a picture now. So here we have the different ones. We have the skin traction all the way on the top left. Then right next to it, we have the external fixation. So on the top right, this is the external fixation. So as you can see, it's like rings, and then the rings have like pins, and then you're going to have to be doing pin site care on every single pin that's in the patient's skin. Then we have the open reduction and external fixation on the bottom left. As you can see, there's pin site care needed there as well. And then on the bottom right, we have the skeletal traction. So this one is kind of weird in this picture, but imagine that string, that white string that you see, that's outside of the skin. So that's going to be attached like the skin traction in the top left corner. Instead of being a skin traction, it's actually a skeletal traction. So the I guess the bar is actually inside, internally inside the patient's skin, and then it's going to be pulled from the strain that's coming outside. It's pretty weird. Like I said, I want you guys to look at other pictures so you guys can understand. But this one is surgically a rod placed inside, and then the string is outside, and then it's going to be attached to weights, and this is going to be able to pull and align the bones where it's supposed to. So the point of all of this is to pull the bones into an alignment. This is why it's something that's needed. It's a doctor's order that's needed, because depending on the patient's fracture and what is going on is what they're going to need. Okay, so this is a box traction. So think about if for the skeletal traction, imagine if the rod was here, and then the string was here on the top. The string would be attached to something similar to this, and then it will have a weight. But the rod will be inside the patient's skin, whereas in the box traction, it's basically like a little boot, and it's like pulling. So there's nothing surgically placed inside. Okay, so that's the difference between the skeletal tractions and then the skin tractions, because one, like the last three that we spoke about, those require pins and surgical placement, whereas the bucks and the skin tractions, they don't. So for the tractions, the same thing. The 5 P's every 1 hour for the first 24 hours. You want to make sure that the body's extremity is aligned. You don't want to touch the weights. So a test question for the weights: who could touch the weights? You can't touch the weights as a nurse. The CNAs can't touch the weights. No family members could touch the weights. No one could touch the weight. Only the provider or the person that is set up to do it. So the people that have like the authority, but the nurses are not allowed to touch the weights. They're not supposed to do anything. So let's say I want to give you like a kind of like a quick example. If you guys get a question that the weights are on the floor or something like that, you do have to tell the provider. You have to call the provider. You can't lift the weights up. You can't do anything, because the reason why is that you don't know where to properly align the patient. It's going to be the provider. So if you get a question and it says that you walk into the patient's room, or a CNA or a family member tells you that the weights are on the floor, you have to call the provider immediately to realign the patient and also put the weights where they're supposed to. Okay, the weights are supposed to be hanging freely, not resting on the floor or anything. Okay, even if the patient is in pain, what you do is give them medication. You're not going to be touching the weights at all. So there's, even if the patient tells you something, you are not touching the weights at all. Okay. If you see that the patient is still having muscle spasms still attached to these tractions, you do have to tell the provider as well, because that means that the traction is either not aligned correctly or something is faulty in it, because the reason for the traction is to prevent those muscle spasms. So if you see that they have muscle spasms, that's something that you have to report. Okay. All right. I think, all right, so pin site care. This is something that we're going to be doing on the skeletal the skeletal traction, the external fixation, and the open reduction and external fixation one. You want to make sure that you're looking at these pin sites for any drainage and redness, loosening of the pins, and any tenting of the skin. Okay, tenting of the skin is basically, I would look up a picture, but like the skin is kind of like going up and traveling up the pin site instead of curing around it. So this is not good, because once the pins have to get out, the doctor's gonna have to cut the skin and rip the skin, and you don't want that. So if you see like the skin rising up onto the pin, you have to let the doctor know. Okay. Now, for you to do the pin care cleaning, you need to know that we use chlorhexidine. We don't use alcohol. We don't use anything else. We use chlorhexidine. Okay, unless whatever the hospital requires, but for test purposes, it's chlorhexidine. You are only going to use one cotton swab for each pin. You're not going to use one cotton swab for more than one pin. Why? Because let's say that one pin is not infected, but the other one is infected. You're basically putting whatever germs you got from one pin to the other one. Now you infected the other unaffected pin. Okay, so you do not want to cross contaminate these pins, and you're supposed to be giving pin site care once a shift, 1 to 2 times a day, or per facility protocol. So usually once a shift is twice a day, because you have your morning and afternoon nurse. So just in case you guys get that in the test, it's usually once a shift. Okay. Now the medications for pain that we could give these patients are opioids and non-opioids, like Tylenol, Advil. We could give them morphine, etc. And we also could give them muscle relaxants if they have muscle spasms. Stool softeners are very important, because since they're going to be immobile, you want to prevent constipation. And then antibiotics have to be given as well to the patients if they have like the open fractures, because like I said, the prophylaxis. So complications that we could see on a patient with a fracture is the compartment syndrome that I was talking to you guys about, fat embolism, and a venous thromboembolism. So we're going to start off with compartment syndrome first. So for compartment syndrome, we are going to see the patient with unrelieved pain. That's like your number one, like whoa, something's happening. So what happens is that there's pressure inside the patient's fascia, and then this could either be because of tight cast or hematomas, which is like blood stationed in there. So it's going to lead to local ischemia, and then basically the low blood flow is going to cause capillary vasodilation. It's going to increase the edema, which causes like pressure in that area, and then it's going to reduce perfusion, because if you have edema and you have compression, obviously you're not going to have enough areas for the perfusion, because of that compression. So the problem with compartment syndrome is that if it's not treated properly or right away, this could end up causing nerve damage and necrosis. And once this happens, amputations might be needed. Okay, so usually your biggest sign of compartment syndrome is intense pain that is not relieved by medications. This is why it's very important to do your 5Ps every hour for the first 24 hours. And if the patient is taking medications and you keep on doing the pain assessment scale and their pain is staying the same or it's getting worse, then that's kind of something that you want to call the provider about, just to make sure that they don't have compartment syndrome. Okay. So this is kind of like a picture of compartment syndrome. As you can see, the patient's skin compared to the other extremity is very, very pale, meaning that there's no circulation in that area. The patient is probably like cold to touch. And then apart from that, maybe the patient is saying that he has severe pain that's not getting relieved. So it all depends on the patient. But as you can see, it's very, very pale, meaning that there is no circulation at all to that area. So the assessment for compartment syndrome, like I said, is the 5Ps, and then the manifestations will be the unrelieved pain, the paresthesia, the paralysis, the pale skin that we saw in the picture, and hardened muscles. So basically, as a nurse, we want to prevent this. So that's why we do the neurovascular assessments every hour for the first 24 hours and then every 4 hours around there. And if we see anything that's suspicious, we are going to report it to the healthcare provider. We're going to also educate the patient to let us know if they're having unrelieved pain, if they see that their extremity is turning pale, if they're having numbness, if they have like a sudden change in like movement and things like that. Anything abnormal that they see, you want to educate your patient, because maybe they see it when you're not there, and then they could give you a call as soon as possible. So another complication for a fracture is the fat embolism. And usually the patients that are above 70 years old are at high risk for this. And for your exams, I want you guys to know the manifestations for this, because you need to know the difference between a fat embolism and a DVT. Okay. And then the one that you have to do, well, the one that you have to make sure that you know is that DVTs is not going to have this late sign of cutaneous petechiae. It's only going to be the fat embolism. So the cutaneous petechiae is going to be only seen in the fat embolisms. When you assess the patient for fat embolism and DVT, the early signs are exactly the same. They're going to have dyspnea, which is trouble breathing, increased respiratory rate because of the trouble breathing, decreased oxygen saturation, headache, respiratory distress, tachycardia, confusion, and chest pain. All of these things are going to be normal, like early findings, as well as like edema and redness to the skin and things like that for the DVT. But for the fat embolism, make sure that you have on your notes that cutaneous petechiae is only seen in fat embolism. Okay, so your nursing care for fat embolism is that you want to maintain the patient on bed rest and prevent this from happening, which is immobilization of fractures of the long bones. And then for the patient that gets a fat embolism, you have to give them oxygen. You have to give them corticosteroids if they have cerebral edema, vasopressors if they have like increased like blood pressure and hypotension, to increase their blood pressure. You have to give them fluid replacement if they're in shock, and then anti-anxiety medications if the patient goes into like an anxiety attack. For the venous thrombosis, we're trying to prevent this. So it's understanding that the patient has to do bed rest because they have a fracture, but like for example, if the patient is not on a traction, you want to have the patient ambulate as much as possible. Now, if you have a patient on bed rest with a traction, what you want to do is, as a nurse, help these patients move the extremities that are not that are not hurt or damaged on the traction. So let's say that the patient has a traction on the right leg. You want to have the patient do movements on their left leg, move their arms, move their shoulders, promote circulation during that whole entire time. You want to put the anti-embolic, the stockings. I'm so sorry for like the noise. My family is so loud. Give me a second. All right, so anticoagulants is something also given in hospitals. So like heparin or warfarin is usually, enoxaparin is also given. It's common. So you're gonna see that the patients are going to have like prophylaxis, anti like enoxaparin and anticoagulants, and then you're also going to give them fluid intakes, rotate feet and ankle on the affected side if possible, and then you want to monitor signs and symptoms for DVT, so swelling and redness of calf. So, like I said, again, fat embolism, the difference is that they have the cutaneous pedichet. So make sure that you guys go on Google and look up like little pictures of it so you guys can know, because on the exam they might give you like they might show you a picture of cutaneous pedichet, and it's gonna ask you like, oh, what disease, or what does the patient suspect the patient has, what does the nurse suspect the patient has if they see this on assessment. Okay, so it will be a cutaneous pedichet, and then it's gonna be due to a fat embolism. It's not gonna be DVT. Okay, so for osteoporosis, we're going to talk about it a little bit because it's one of the risk factors for a fracture. So, osteoporosis could be due to like increased age, and then also because of history of smoking, high alcohol intake, um, things like that. So that's why you guys want to do like the bone densities, um, you know, things like the, I guess, like monitor the patient. If the patient has menopause, you want to tell the patient that they have to start doing their bone densities, because menopause and low estrogen levels could cause osteoporosis. And then osteoporosis is going to lead to fragile bones that could lead to fractures. This is why usually the fractures, like the hip fractures, are seen a lot in the elderly, because when they fall, that's usually what they fracture, and then they're gonna have to have like a hip replacement. Okay, so the treatment for osteoporosis is usually giving them calcium and vitamin D. This is usually for the prevention. And then secondary osteoporosis could happen because of hyperthyroidism, diabetes, Cushing syndrome. So different diseases and diagnoses could cause osteoporosis. And then medications could also cause osteoporosis, like long-term use of them. So anticonvulsant medications, loop diuretics, corticosteroids, thyroid medications, all of these have risk factors for osteoporosis. So usually when the patients are on long-term use for these medications, you're going to see that the patients are probably going to be on calcium and vitamin D supplementations, just because of the fact that they are going to be at risk for osteoporosis. Okay, the biphosphonates are the ones that I spoke about a little bit earlier, which was to prevent and also to treat osteoporosis. So these are basically given orally or IV. You could see that the patient might be prescribed alendronate a lot, which is given to to patients, like just, for prevention, or when they have osteoporosis, they're gonna give them. Now for biphosphonates, I want you guys to know that for the patient teaching, when they drink this medication, they have to take it with 8 ounces of water in the morning, and they have to sit upright for 30 minutes, because the reason why they have to sit up for 30 minutes is because it could cause ulcers in the esophagus. So if they lie down, it will kind of regurgitate in the esophagus and cause ulcers. Okay, so that's very important for you guys to know about biphosphonates. For the osteoporosis, like the illness prevention and things like that, like we talked about, The patients have to monitor their weight. They have to do sun exposure for vitamin D. If they're not getting enough calcium in their diet, they have to, talk to their doctor to get supplemental diet calcium, supplemental vitamin D if they can't go outside for 5 to 15 minutes. You want to educate these patients on like all the risk factors that we talked about. Sedentary lifestyle is one of the biggest issues, so you want to tell these patients about the weight bearing exercises that we spoke about, and at least if they can't do weights, at least have them walk around 30 minutes every day, at least 4 to 5 days a week. This is going to promote, at least some exercise and not cause such a sedentary lifestyle. Okay, so amputations is something that you might see if the patient has like compartment syndrome and they end up getting necrosis, or if the patient has diabetes or necrosis anywhere in the extremity. um, Amputations could be different. It could also, like, different reasons. It could also be because of like an infection that has transferred into the bones. So there's different reasons why a patient might get an amputation. But as a nurse, you need to make sure that you know that for your nursing care for an amputated patient, we want to relieve the pain for the patient, minimize the sensory perception, promote any wound healing, enhance their body image, and give them self care. Okay, so phantom limb pain is something that is very common, especially in the patients that just got an amputation. And we do have to tell the patient that this is something normal. They're going to complain of pain that is basically supposedly in the area where the the body part that was removed was located. So, for example, like if you have a patient that has an amputation above the knee, these patients are gonna feel pain below the knee. The reason why is because those neurotransmitters are still like kind of like bouncing back in that area, and then it's causing them pain, and then like it's like an intense burning feeling that they're gonna have, and it's like very, very painful. You do have to tell the patient and remind them that that that's something normal. You have to give them medications for it, and then remind them that that body part is not there anymore. Okay, so basically that's what the management is. Let's see if I'm missing anything. Oh, as a nurse, just make sure that you know that like this is something that is normal because of the trans. Okay, the reason why is that because since the body thinks that there's still that limb there, the neurotransmitters are kind of signaling and like bouncing back, which is causing that pain. Okay, so you need to make sure and recognize that this patient is actually in pain, that they're not making things up just to get like medications. It's something that actually happens when a patient has like an amputation. So make sure that you give them their medications, and you tell the doctor in regards to this. Now, once the patient has an amputation, you do want to prevent um, DVTs, pain, and stuff like that. One thing that you want to do is range of motions with your patient. You want to have a firm mattress with them, and the main thing that they also love to ask on the exams is the prone position every 3 to 4 hours. This is going to prevent the extremity from, I guess, like the muscles from, I guess, hurting. I think it was, it's something that it prevents them to have pain and cramping of their muscles. Okay. And then lastly, we're going to touch up on pressure ulcers. So this is kind of like fundamentals again. But like I said, these patients are going to be immobile, and they're going to have like risk for ulcers. So let's talk about a little bit about the risk factors. So the risk factors, apart from immobility, we have smoking, obesity, impaired tissue perfusion, anemia, diabetes mellitus. These are all risk factors, but in this case, our patients are going to be immobile. Okay, this is why we have to try to change them every 2 hours. but unfortunately, some cases we won't be able to. Okay, so you need to know the difference between all the stages of pressure ulcers. The first stage is usually when the ulcers are going to start. So it's a non-blanchable redness, erythema, intact skin. So when you press on the skin, you're gonna see that it doesn't blanch. You're also going to see it usually in the bony prominences like the sacrum, the elbows, the heels, things like that. So those are like the main focuses for you. And then the skin is either gonna be warm or cool to touch compared to the other part of the extremity. Now for stage 2, think about like a blister. So this is like a partial thickness skin loss. This could be a blister that is closed, so it's still like a bubble formed, or a blister that popped. Okay, so it could be both. It could be a popped or intact blister. Okay, there is no scarring, there's nothing, it's just like a little popped blister. Okay, then for stage 3, this is your full thickness skin loss. This is when damage and necrosis starts to occur. Okay, in this case, bone and tendon is still not visible, but it is a deep crater, and sometimes it does have tunneling. Okay, there could be drainage, and these patients could be at risk for infections like MRSA and things like that. Then you have your stage 4, which is your full thickness tissue loss, which is where you might see bone, muscle, tendons, everything. Not all stage 4s are going to see bone, so don't get that confused. Just because you don't see bone doesn't mean that it's not a stage 4. And then these patients are either gonna have slow, which is like this tan yellowish thing, like material in them, and then eschar is like black, so it looks like necrosis. Okay, and these are very, very deep. Then you have your unstable, unclassified, full thickness skin or tissue loss, which is basically, think about like a scab that you don't know how deep it is. So the stage can't be determined unless the patient is taken to like surgery and they remove that top layer and then they see it down in the bottom. So that's when they start to classify it. But other than that, visually you can't see it unless, like I said, you go to you have the patient go into surgery and then they remove that area, and then they could see if it has migrated down or if it's like a stage 1, stage 2, etc. Okay, so for your nursing assessment, you're going to use a Braden scale. You guys are probably familiar with the Braden scale because you guys had to do it for fundamentals, which is basically it's basically gonna tell you, sorry, it's basically going to tell you if the patient is at risk for skin breakdown and how much of a risk they have. So the higher the score, the better their outcome is, because then they don't really have a risk. So for example, if their total score is like around a 19 or a 23, that means that they're really not at a risk for skin breakdown. Once they hit like the 13, the 10, that's, they are moderate and high risk. And then anything from 9 or lower, they are really high risk of skin breakdown. So when you're doing the Braden scale, you're looking at sensory perception, you're looking at the skin's moisture, the activity that the patient has. Is the patient really immobile? Are they able to walk every 2 to 3 hours? Or are they bedbound, etc. Their level of activity, and then if they have little or no activity, basically you're gonna look at their muscles and check if they are having like atrophy and things like that. Then you're gonna look at nutrition and friction and shear. So for nutrition, you're looking at, is the patient eating good? Are they eating high proteins? Are they not eating at all? So usually nutrition is very, very important, especially for wound healing, because they have to be eating a lot of protein. The way that you can monitor nutrition and protein and things like that is by looking at the albumin level. So the patient's albumin level has to be above a 3.5 for the patient to have like a good like for the patient to have like a good chance of like fast healing. If not, if it's below 3.5, you do have to tell the provider, because usually they're either gonna have to increase their protein intake or administer albumin depending on how low it is. And then friction and shear, this is why we use um I guess I forgot what it's called. Crap. When we're moving the patients, we're using the I forgot the actual name. It should be in your in your fundamentals. I'm just thinking about what we do in the hospital. But basically, we use like a sheet or something to move the patient up in the bed to not cause any friction on the skin instead of moving the patient up. I totally forgot, like I blanked out right now, but there is like a name for it. So every time that you move a patient up on the bed, you have to use that. All right, I think. Okay, another way to prevent skincare when a patient has a skin like if they have risk for skin breakdown, you want to make sure that the head of the bed is below 30 or at least 30. The reason why is because imagine that the patient is above 30. Obviously, if the patient has to be like in high Fowlers or Fowlers, obviously you have to leave them there. But if it's not necessary, you always want to keep the head of the bed low, like at 30 or lower, because their weight could it's going to be on top of the sacrum, and the sacral area is one of the areas where usually patients have skin breakdown, and it's very very bad and painful. So the less weight that you have on these areas, the better relief that they're going to have. And then you're going to have to be turning the patient every 2 hours if they're in bed. If they're in a chair, it's every hour. Okay. So for the treatments, you guys don't have to go into depth about the treatment. Just know that for stage one, you just put like a little it's like little it has like a little cream. It depends on on what the doctor orders, to be honest. But it's also for you to be looking out. It's like a clear tape looking thing. Um, it's like a clear dressing. And then for stage two, three, and four, you're going to be either using like ointments, packing, packing supplements. So it depends on what the doctor orders and what the patient has in regards to that. Like I said, for med-surg, you guys don't have to really go into that. If you guys want to talk, like go back to it, it is in your fundamentals, but usually you don't really have to know exactly the treatment, because it's gonna depend on the doctor. Okay.